Oh, there we go.
There we go. Okay.
There we go. Okay.
Okay. If you didn't hear me before, welcome to the topical. We're here to learn about the recovery and community team here at the DBHR in our recovery support services section. These are my colleagues, and I'm going to turn it over to them to introduce themselves and get started. Thanks for joining.
Lisa, you're muted. Are you
I'm muted?
January recovery. Oh.
Am I starting? I'll just go.
So quiet.
Go right ahead. I don't know who wants to start introducing. You guys want to just start introducing yourselves and then.
Yeah, I'll go ahead. Hi, everybody. I'm Maida Hogan. I use she, her pronouns, and I oversee the Peer Pathfinder program and also the HOST program, which stands for Homeless Outreach, Stabilization, and Transition. And I've been with the Healthcare Authority for about 4.5 years. And I am excited to present today.
Good morning, everybody. I'm the one that mutes themselves in the beginning of a
There
presentation. Yes, my name's Lisa Bennett Perry. I am the Recovery and Community Supervisor here at HCA. And this is my wonderful team with great amount of knowledge that they're going to share with you today. So we're pretty excited about that. I'm also going to present filling in for some people that were busy out in the community today. So thanks. Brian?
Hi, I'm Brian. I'm Brian. I'm a program manager for two short-term housing subsidies contracts, which we'll talk about later. Been at HCA since February, I think, of 2024. I've always worked at HCA.
Always.
No, yeah, sorry, I was stalling. It's February 2024 is when I started. Prior to this, I was at the Department of Commerce doing homeless housing stuff there. So this is my wheelhouse. Lauren, have you gone? Or did you already go?
No, I didn't. Thanks, Brian.
Well, it's your turn.
Hello, everyone. I'm Lauren Robbins. I am the Clubhouse Peer-run Organization Program Manager, one of them. Dre Bean is my counterpart with that, but I'm not able to be with us today, so I'll be presenting on Recovery Cafes, as well as Clubhouse and Recovery Community Organizations. Oh, I've been here since November of 2021.
And I think I'm last. Can you hear me all right? Hi, everybody. I hate to not have my video on, but my internet is not happy with me this morning. So you will not be able to see my face, but my name is Kathy Geisler. I'm on Lisa's team. I've been here for about 3 years, and I run the Housing First program for HCA, and I'm looking forward to sharing more about it with you in a bit. Thanks for joining today.
Well, I'm going to go ahead and start out by sharing my PowerPoint for the PATH program. Well, let me get to... Way to go.
Oh, not the dreaded calendar, Lisa.
I know. I'm going to drag. Sorry, guys. There, how did that go? And you know what? I'd rather have it this way instead of the full screen, because then I can't see people and that just doesn't feel natural to me. So I hope that's okay with everybody. So again, this is the PATH program. So PATH program stands for the Project for Assistance in Transition from Homelessness. PATH has actually been around since 1990. It's one of the longest running federal funded street outreach programs. And HCA has been involved in the PATH program since the beginning. Well, actually, it's not HCA. The Division of Behavioral Health and Recovery has been involved with the PATH program since the beginning of PATH. We transitioned to HCA probably about 7 years ago now or so. Just a little bit of history about PATH. PATH is a SAMHSA funded program or formula grant. It was originally funded through the Stuart B. McKinney Homeless Assistance Amendment Act of 1990 and was reauthorized through the Consolidation Appropriation Act in 2023. PATH grants are distributed annually to all 50 states, and awards are allocated to local public nonprofit organizations, state government, and they're also known as PATH providers. So who does PATH serve? PATH serves individuals that are experiencing serious mental illness, who are also homeless or at imminent risk of homelessness. In Washington State, the biggest percentage of people that we serve are actually homeless. And I'll talk a little bit more about that later. The Healthcare Authority Department of Behavioral Health and Recovery award funds to behavioral health organizations with the goal of full person care and connecting individuals to community mental health services, mainstream benefits, and transition or divert individuals from homelessness. Here are the regions that the PATH program serve. So contacts and engagement. When you think of outreach, what do you think of? I mean, you're obviously outreaching people. Maybe you're outreaching people that want to be found. Maybe you're outreaching people that don't necessarily want to be found. I think it's safe to say that a lot of the people that these programs serve are people that wouldn't have received services if it wasn't for the contact and engagement that our wonderful outreach teams provide. So PATH contacts generally begin in city streets, encampments, and other places not meant for habitation. Like I said, people are not necessarily seeking services at the time of contact. So there's a lot of special care that goes into that. So engagement comes with time, persistence, and patience. Little will change with the absence of trust and relationships. It's very important as an outreach specialist. If you say you're going to do something, you do it. Don't overpromise. And over time, that person, could trust that you're not just going to be that person that makes false promises, which does tend to happen. Well, because we want to help people, we just can't always help people. So not overpromising really builds trust. Particularly in the beginning, PATH responds to immediate needs from the most basic thing, food, water, warmth. But the ultimate goal of engagement is it results in people being connected to mental health treatment, to substance use treatment if needed, healthcare, housing, of course, financial resources, community, and recovery. That's the ultimate goal. Best practices. As I said, we've been doing this PATH program has been around for a long time. We've grown, we've learned lessons over time, but like some of the best practices I wanted to share with you includes all PATH contractors are behavioral health agency. This allows for low barrier intake to essential services and coordination of care. So if these agency, the PATH outreach teams are part of a community behavioral health organization, when they do get people that say, yes, I do want help, that you're able to walk beside them and get them into immediate care because you work for this organization that provides those services. I'm not saying it couldn't happen the other way, but there's a likelihood that it's going to be quicker if you're already part of that behavioral health organization. Also, there's the coordination of care, includes bringing needed physical and behavioral health services directly to individuals when available and necessary. I think one of the best things that our teams can do is get that coordination of care from the organization that they're working at. And a good example that somebody shared with me, and I believe it was for the PATH program, is an instant when an individual was several months pregnant and hadn't received prenatal care yet. They were afraid to go into a hospital or go into a doctor's office and ask for care because this individual was homeless. And also there was, you know, a significant amount of emotional struggles that this individual was dealing with. And so what they did as a PATH team outreach specialist is worked with a nurse to come out and meet that person actually at the encampment and start providing some small steps of care to that individual. That individual with that, that individual was able to build trust that she would, number one, that her baby wasn't going to be taken away from her. She did get the care that she needed. She did get housing, and that's the ultimate goal. Also, over the years, we found PATH outreach staff being persons with lived experience helps that connection. I'm not saying that a person without lived experience can't make connections to people, because that would be a non-truth. But it does increase, based on research, increases the likelihood that a person will connect to that individual if they can themselves say, I've been in your situation and now I'm helping people, as an example. So again, on my next, it says research consistently shows that involving people with lived experience in social services significantly improves relationships, trust, outcomes by bringing authentic expertise, fostering empathy, and creating more relevant, effective, and person-centered programming. Just a little summary of outcomes for fiscal year 2025. In the PATH program here in Washington State, there was roughly 2,153 number of people contacted by PATH funded staff during the reporting period. So contacts are not just for people that are enrolled, but for people that they've that are new. They're not sure. They're not sure if they want services, but there's some outreach. Some conversation about resources or helping a person find food or shelter, this type of thing. But 1,193 of those individuals were actively enrolled at any time during the reporting period. 55% of those individuals were did experience serious mental illness. And 820, and I go into the percent of kind of over serious mental illness became enrolled in services. I'm not sure exactly of the percentage I just put out. I think the rest of that is that there's a missing piece there, and there is also a percentage that is co-occurring. So one of the things that we did see over the years with a significant change, I've been with DBHR for a little over 10 years now, is that in the beginning it was primarily serving people with serious mental illness, and over time it became co-occurring. Not just serious mental illness, but co-occurring. And that's where the Peer Pathfinder program comes in, and Mate is going to talk about that in just 2 seconds. And then 824 participants receiving community mental health services. So of those, 2,000 roughly contacts were made. 824 of those people received community mental health services due to that. So yeah, again, more than 50% of the people, not everybody's going to want mental health services. That's of course choice based on their decision. But and then 164 PATH participants connected to substance use disorder. And Kim, we didn't talk about how we're going to do this. Do we want to go ahead and ask? Do we want people to save their questions till later, or do we want to do it after each presentation?
I think whatever you guys think would work best. Maybe after each of you, just a quick few minutes with any questions.
Okay. So does anybody have any questions for me? Is there anything in the chat?
Nothing in the chat so far, Lisa, other than just some sound challenges for folks.
Okay. Well, if you all think of
there
anything.
There is a question, Lisa,
Okay.
in the chat that I answered, but you can feel free to elaborate or correct me. Is there an age range? And I said 18 plus, but outreach workers don't card folks.
That's a good point, Maida. You're right. It is 18 plus, and you're right. We don't card people. One of the things I would say about the PATH team or any of our outreach teams is if somebody outreaches them and they do happen to be somebody that's under 18, we know this because they've told us that, right? We would then connect them to a program that would make sense that they would be eligible for versus just saying we're not going to help you because you're not 18. Shannon, if you do have somebody that it would qualify or would be PATH would be a useful program for them, I would reach M Jones. She's actually manages the PATH program. I'm filling in for her as the supervisor. And there you go. Thank you, Maida. I would contact M Jones and she could then refer out to whatever area that you're referring to. Does PATH have ability to do direct placement into beds for recovery or detox services? I think it's fair to say that all of our outreach teams have connections to places such as detox services. But is it in there as one of their primary roles? No. But they would connect them to their job is to connect people to services. So I think Maida, would you agree that that's a fair statement? Is that they could?
Yeah, I think those relationships vary across regions. There are some teams that have stronger relationships with, whether that's correctional facilities or inpatient facilities or things like that. It really just depends on the local service matrix.
Thank you. And there you go. Maida's up. She's going to present on Peer Pathfinder, which was built off PATH.
Dang, I love following the PATH presentation because I'm basically like, yeah, all that, and then some changes.
Just say ditto.
Yeah, we'll just take that all as read. Okay, so I'm gonna share. Okay, can you see my PowerPoint?
Yes.
Yes. Okay, I'm not gonna put it in actual slideshow view because then I can't see all of you and I can't see the chat. So I'm just you're gonna have this annoying thing on the side here where you can maybe try and peer at it and see what I'm gonna talk about next. Okay, so I'm talking about the Peer Pathfinder program, and again, it's really similar to PATH, and I'll get a little bit more into that as we go. And forward. Oh, there we are. Okay, so it expands on the PATH model to meet the needs of individuals who are experiencing homelessness and substance use challenges. It's funded by the state opioid response grant, which originally was the state targeted response grant. But basically it's part of the state opioid response grant covers a whole range of services related to opioid use, although it's expanded to other substances more recently. So there's prevention services, there's treatment services, there's recovery, and Peer Pathfinder is part of that whole spectrum. The intent is really to reach those who are most at risk of overdose. In each team, so we have, this isn't updated, we have 10 Peer Pathfinder teams throughout the state, and each team is comprised of 2 outreach workers who are people with lived experience of behavioral health challenges. And the people who are drawn to this are typically people who have lived experience with substance use disorder, which again, as Lisa said, it tends to kind of bring that rapport piece a little bit closer than, if you're doing outreach with folks who don't have that lived experience. Who do we serve? Adults 18 and over. Again, we don't card people. It's not really, we don't expect that our teams will be developing competencies around serving people who are under 18. So it's not really an ideal program for that. Although, as Lisa mentioned, we can definitely make referrals and help to connect folks to services. And sometimes we'll be serving an eligible adult who maybe has minors in their care, and so they end up benefiting as well, even though they're not direct participants in the program. So really targeted at folks who have opioid use disorder or stimulant use disorder who are at risk of overdose. Initially, it started out, it was just folks with opioid use disorder. And then there was a recognition a few years ago that people who were using stimulants and not necessarily seeking opioids could possibly be exposed just because the drug supply is so insert swear words here, contaminated, because everything is mixed together, because there's fentanyl in everything. So there was an acknowledgement that even people who were using, say, methamphetamines could still be at risk of opioid overdose, even though they're not seeking opioids necessarily. More recently, last year, we actually expanded it to include anyone who's using substances who might be at risk of overdose, just a further acknowledgement of the kind of exposure that people might have if they're, living outdoors and kind of really using anything. Yeah, anyone who's at risk of overdose or drug poisoning. And our priority population is really folks who are experiencing homelessness or who are utilizing emergency room settings. So the thinking there is if we're really looking to intervene with folks who are most at risk of overdose, those are going to be people who are living outdoors or in places not meant for human habitation, or people who are actively dealing with medical emergencies related to their substance use. So that could be, well, we'll get into that. So what do? We do engagement. Again, this is really modeled on PATH. So what happened initially was, so the PATH program ran for a while, and it was really designed to serve folks with serious mental illness. And there was an insight that sort of came out of the experience of people doing that outreach, which is there's this whole other population that needs these services, but they're not eligible because they don't have serious mental illness. So there are people who are experiencing substance use disorder, who would really benefit from a PATH-like program, but they're not eligible to enroll in PATH. So when we got the state opioid response funding, basically they just took PATH and said, can we make this for people with substance use disorder? Can we do an outreach program exactly like PATH for people with SUD? So we're doing a lot of the same. It really mirrors PATH in terms of the types of services provided, and the way that the services are provided. So peer pathfinders are going to places not meant for habitation, again, homeless camps, vacant buildings, wooded areas. They're also going to hospitals and emergency departments. Initially, there was an idea of embedding one of the peers in the emergency department to sort of catch those folks who are coming through with those substance use disorder related medical emergencies. Really kind of hit a bump because we only have one FTE for that in each program, and the emergency departments were really kind of looking for 24/7 coverage when it comes to that. So we've got a few programs that have actually successfully embedded a peer in the emergency department, and others just have memorandums of understanding about referrals or varying levels of engagement with the emergency departments to make sure that they're able to contact those people who are coming in with SUD related medical emergencies. Public spaces, libraries, churches, soup kitchens, and then also peer pathfinders can take referrals from really anyone in the community. So some of the teams have really strong relationships with law enforcement, and they'll be able to get referrals that way. And they've been operating most of the communities that we have peer pathfinder teams. They've been continuously operating for about, almost 10 years now. So they have developed sort of a reputation for what they can do. And so referrals come in from all kinds of places. Services provided, case management services. So service planning, there's an expectation that as soon as possible in engagement with somebody, you're coming up with, working with them to sort of define what their recovery goals are and figuring out what you can do to help connect them to resources and to follow through and achieve those goals. And then connecting people to other services. A lot of that, it's really client-centered, so it really depends on what the person's goals are. So it could be, I really need to get into housing.
Okay, so we're going to focus on that. Or it could be, you know, I really want medication for opioid use disorder. Okay, so we're going to focus on that. Yeah, there's a lot of different things that that peer pathfinders can help people access that might support them in their recovery. And then the peer pathfinders also, so they kind of have two hats. So they have sort of the case management hat and, you know, referrals and helping people access resources. And then they also have their peer hat. So they're able to do that peer counseling role where they can use their lived experience to sort of help somebody imagine what recovery could look like, and promote that hope and self-efficacy that that's so central to recovery for folks. Okay, also can provide referrals to all kinds of, I mean, again, it depends on the community, what's available, but most of the Peer Pathfinder teams have really good relationships with a lot of these resources in their communities and can do what we call it like a warm handoff to a provider. Okay. Data collection and reporting. This is one of my personal bugbears because before I had this job forever ago, when Peer Pathfinder started, I was overseeing an outreach team and we took on Peer Pathfinder because we had the Path program, and we were reporting data in HMIS, and then we were also turning in a spreadsheet, and it just didn't really make sense. And other teams were having the same thing, like it doesn't, who's looking at this, like how are we using this data, what does this even mean? And so coming into this position, I was really fired up to sort of connect that circle, to have that loop come back and have the data be actual feedback that the teams could use to, you know, improve their programs, to understand what kind of impact they're having, and that sort of thing. So we're currently using REDCap. And we have, through the SOAR grant, we have a relationship with research and data analysis at DSHS. So they pull the data and then generate a report that looks like this every month. So this is, you can see it's outdated. It's only through last July, but this is kind of what it looks like, so you can get a sense. So we've got really the only metric for Peer Pathfinder statewide is that annual target. That's the number of people that we want to enroll statewide each year, and consistently our teams are enrolling more than that. So you can see this particular report is 3/4 of the way through the year and we've already exceeded our annual target for enrollments. So that's, I mean, that's fun. It's fun to win sometimes, and I love to tell the teams like, y'all are just knocking it out of the park. Okay, but this is what the report looks like. So we get our new enrollments per month, and then we got the demographic information here, so we can kind of look at that and say, does that, you know, are there any obvious blind spots, anything kind of stick out in terms of who's underserved or overserved? And then outreach location, most of them are engaging people in street outreach, but then they're also in these different types of facilities. We have broken out by substance, the substance use by substance, so that we can actually track. Because if somebody's using opioids, they're going to want medication for opioid use disorder. If they're using stimulants, they're not going to want MOUD. That doesn't make sense, right? So we want to be able to track who's accessing what type of treatment services. Living situation, most folks are homeless, and then different types of engagements and referrals. So again, this is outdated. We don't use the phrase harm reduction anymore. We say overdose prevention. But so I get this report, and then I get a separate one for each provider. So I can sit down with the providers and say, hey, you know, it looks like your enrollment's kind of tapered off, or it looks like you're, you know, only serving people who are older, or, you know, things like that, and give them feedback about how to improve their services. The future, this was such a hopeful thing. This was before the budget got really gnarly. So this is actually a little baby frog from my pond. You can see it's shedding its little tadpole tail. So we switched from HMIS to REDCap. All of this happened about 1.5 years ago. We expanded the eligibility to include anyone who's using substances who may be at risk of overdose, and we provided a extra funding intended for a wage increase for the peers, because that was the feedback that we got from providers. Would love to expand to more rural and tribal adjacent areas around the state. With only 10 teams, we're really kind of limited in our geographic scope. and there's a lot of people who don't get served who would benefit from these services. I'm going to leave it there because I actually have no idea how long I've been talking. Did I go over?
Yeah, how are we doing on time, Kim?
Yeah.
Are we?
I was like making fun of other folks for like timing themselves beforehand. I was like, who times themselves? Please.
Lauren
No,
Robbins.
like,
Okay, I think I'm up next. Let me share. Will somebody let me know if you can see the program guide?
We can
We're
see.
good.
Awesome. Awesome, thank you. And again, I apologize for not being able to be on camera. My technology is not happy today, so hopefully you can hear me fine. So again, I'm Kathy Geisler, and I've been overseeing the Housing First and Housing Stabilization programs for HCA for about 3 years. And I have this fun little program guide that our consultant was able to create for us about a year ago. So there is a few things that are out of date, but the basics of the program are still the same. So I'm not going to read this verbatim, but I will just go through some highlights of the program like Lisa and Maida have done, and just share a few things about how it's going. And please put questions in the chat. I think when we're done today, we will get, like Lisa said, we'll provide some more information for you all on these programs and who to contact if you have more questions or want to have county-specific referrals or anything like that. All right, so we'll go to overviews. Probably most of you on this call are familiar with Housing First, so I'm not going to belabor it. Oh, I saw a current and former Housing First staff in the chat, so I won't call you out, folks, but I'm so glad to see you here. So you may know all of this already. So most of you are familiar with Housing First. It's been around for a few decades, and it has shown a lot of success, and we've been using it at HCA for quite a few years now. And just briefly, some of the Housing First principles: immediate access to permanent housing without readiness requirements, a lot about client choice and their own autonomy, freedom to decide how they want to be housed, if they want to be housed, etc. Recovery orientation without expectations, encouraging them to choose their own journey of how their housing looks like and their recovery, etc. Client-driven supports, and social and community integration, helping folks get connected with their community in whatever ways make sense for them. And some of the background on our end from HCA about this: in 2022, just before I started working for HCA, the state proviso tasked us, the HCA, to create and expand housing supports for adults with behavioral health conditions. And so that the Housing First program grew out of that, and it offers no barrier and low barrier services to folks without requiring treatment. And I'll go into a little bit more of the basic criteria for the program here in a minute. And some of the partners we've worked with, we work with Advocates for Human Potential for our consulting. They do the webinars for the program and dive into all kinds of interesting topics for the staff of our program. We've also worked for several years with the Department of Commerce, who supported our HMIS. We used HMIS similar to Maida's program for a couple of years, and we have also switched to REDCap recently, which is a DSHS affiliated data. So that's not reflected here since this is about a year old, but we worked with HMIS for a couple of years and they supported us. And then DSHS oversees, similar to Maida's program, helps us with our research and data analysis. And here is a map of all of the agencies and counties. I guess the agencies, yeah, they're here. Okay. All the ones that are highlighted are counties where we have a Housing First or Housing Stabilization program. So as you can see, they are scattered throughout the state. Tried to pick some places in counties that aren't always served as much. So, for example, I live in King County, so I don't have anything near me. I'm going out to Aberdeen and Vancouver and Spokane and Wenatchee and all over the place. So here's a list of where we're located. And these have all been in the grant for the whole time we've been functioning as a program since about 3 years ago now. And the basics for the program are the individual must have a behavioral health condition, mental health condition. They must be either experiencing homelessness or housing instability, and they have to be below the 50% AMI for that county that they reside in. So we tried to have as low barriers as possible to get into, to be eligible for this program, in keeping with the Housing First philosophy of low and no barriers. And I won't go into this too much. I think all of you on the call are probably familiar with what behavioral health conditions are, but just a few things about impacting quality of life. Systems can persist for a long time. It can affect your energy levels. Typical coping skills may not work for that person. It may cause other issues in social or other areas of your life. So it can really affect really all areas of your life. What is a low barrier program? Again, probably most of you are familiar with what a low barrier program is, but really just trying to keep as few barriers for folks to access services so that they don't have to, I guess, jump through a lot of hoops to get the help that they need. And we go into some detail here about possible scenarios and what it might look like to practically be a non-barrier program. But the bottom line is a spectrum of services will be provided to meet the person's needs and circumstances, and not just serve clients who are ready for sobriety or who are actively wanting to engage. So the agencies that run this program across the state really work with folks in all different circumstances. Some are very ready to engage and they have their list of everything they want to work on. And other folks are not really in that space and they need a peer to walk alongside them. And we'll talk a little bit about peers here in a minute. So the staff roles that we have in each of our programs for Housing First, every site has a program manager / supervisor. Every site has at least 2 peer counselors in their group. Probably all of you familiar with peer counselors, so they must become certified peer counselors within 6 months of being hired. A lot of folks come to the program with that already in their background, having lived experience to support their clients. We have housing specialists, which sort of functions like a case manager. And then some of the sites have residential managers. Those are places that have, maybe they have a lot of PSH or they have housing that they own and they need a manager to oversee some of that. So a few of our programs have that included as well. We also have I oversee a smaller program called Housing Stabilization. So 3 of our 10 providers run this program in addition, which is kind of like an extension of Housing First, but during off hours. This could be weekends or late nights, right? Instead of closing. I started hearing an echo. Okay, I think it's gone. So this could be a weekend or a late night outside of business hours. So these 3 teams, which are in Vancouver, Aberdeen, and Spokane, they help folks outside of those traditional hours, or they have crisis lines that folks can call when they need some assistance. And then just a little more about the review of the program. Again, I won't go into reading all of this detail, but some of the things we offer is that we have webinars several times a year, hosted by our consultant. We've had so many topics over the years. I try to get feedback from the staff over what would be helpful for them to hear and to dig into as a group. There are, I don't think I mentioned, but there are about 60 staff at any given time between these 10 agencies that run Housing First. And they're scattered all across the state. So we come together at least a few times a year and have these webinars and go through topics like landlord-tenant laws, client advocacy, asset mapping, harm reduction. We've gone into a lot of peer counseling and other topics. So we try to, just get feedback from the staff over what they'd like to learn about. And then we meet either in person or virtually with all the staff once a year. And that's been a really great time to gather with everybody and just learn from each other and be able to see who else is running that program in other parts of the state and get to know each other. We have project plans at the beginning of every year where the staff lets me know what they plan to do, sort of like a roadmap for the year. And then we check on that throughout each quarter to see how the goals are going for the program. They also have monthly and quarterly reports, and I'll show you an example of what one of those looks like in another slide. And yeah, just a few highlights here. You know, the program can help clients with having peer support, housing specialist or case management support, some financial assistance. There are some stipulations on that, like as far as how much can be paid or what can be paid, but they can help with a fair amount of things. Most things that get help financially are things like moving costs, right? Someone coming into housing for the first time and needing assistance moving in, maybe getting some basics for their housing, maybe helping them set up utility bill, some things like that. And let's see, what else do I want to highlight here? Yeah, I won't go into the detail, but this is just a sample of the kinds of things that the program can help with. And it's all on a case-by-case basis. The managers have limits on what they can pay for, and then they have to make an exception request to me if it's above a certain amount. So there's some of that. And we also, every client has to have a goal plan or a treatment plan that they set up at the beginning of their intake or time with the agency they're working with. And probably all of you are familiar with SMART goals. So we really try to encourage them to be the SMART goals, right? Specific, measurable, actionable, relevant, and time bound. And those are supposed to be revisited at least every 90 days to update on the progress, or maybe the person's goal has changed. So this program is really focused on like regular interaction with those folks who are in the program and helping them achieve their goals or work on their goals. And then we just, I had my consultant put a few things in here about how important documentation is and some of the best practices around documenting. Because we, as Maida said before this, you know, data might not be everyone's favorite. Maybe it's not the fanciest of topics, but it's important for a lot of reasons, and being able to continue the work and see how it's going in the different communities and who they're reaching, which you'll see an example of the data in a minute, which is, I'm gonna skip Pat. This, so this looks a lot like Maida's, as you might have noticed. Again, this is about this is from the end of October 24, so it's not updated data, but this is what our data looks like. It highlights things similar to Maida's as enrollments per month, what's their living situation, some demographics, what are the different services. As you can see, barrier removal, which is what we call anytime the client has some funding assistance that isn't for housing, it's called a barrier removal. So that's very high. This means they got help with rent. And very high, of course, is also case management, housing assistance, community mental health is a big referral that a lot of folks get, employment assistance. So anyway, I won't belabor it, but this is some of the info that I get to see. And we just talk with the programs. We highlight, you know, how their data is looking and what they might need assistance with, or yeah, what's going on and what trends we might see. And then at the end here are just some, I believe we'll send this to you all along with our PowerPoints, I think. But anyway, there's just a few helpful links in here, like to Pathways to Housing. Some of you may be familiar with that, or the fact sheets for my program. And this is what I look like. I am a real person. And I'll put my email in the chat if anyone has questions. I am looking to see if anything came up while I was chatting here. Okay, I don't see any specific questions from me right now, but I'll give you all a minute in case anyone had any, and I'll put my email in the chat. And thank you all for letting me share today. All right, there's my email for Housing First. All right, and I think, is Lauren or Brian up next? I can't recall.
I guess me, because my camera's on.
All right.
It's
All right, I'll
Brian,
hand it over to you, Brian.
You know what's funny? I've been working for the state for almost 10 years, and I didn't think to use an agency template for my slides, so I apologize if it's kind of sloppy. And also apologize, why am I the only person on my team that didn't think to do it? Anyways, so...
Well, we're pretty upset with you.
You know what? I hope that this, it gives me a little bit of edge, I think. Anyways. So, hi, I'm Brian. I've been working at Healthcare Authority for almost 2 years now. My job basically is to manage these two pools. You guys can see my PowerPoint slides, right? I thank you, Maida. I am the bad boy of
Yes.
HCA, I feel like. Okay, so anyway, so when I started in February 2024, my job was to kind of manage this pool of money on the right that I'm going to call subsidies, which at the time was about 4.5 million for the biennium or two calendar years. In this biennium, the amount went a little bit. It's about 4.6 million for 19 providers. And they're scattered to the intent of this funding was a proviso to fund short-term housing subsidies, which I'll kind of define more in a second, for people that have been impacted by a substance use disorder, and it was specifically set aside for the 5 most populous counties in the state. Well, the 5 most populous counties in the state, including the Snoqualmie tribe, which is its own thing. And all of these providers, they each determines their own eligibility for people that they're helping, but these subsidies are just kind of like an extra little tool in their toolbox to help the people that they're already helping. And all these people they're engaged with, all these providers are engaged with a lot of anything you can probably think of in terms of substance use disorder response. And then starting in July, which I apologize, I'm still getting my feet wet for my other subsidies, which I'll call the outreach subsidies, because most of these providers are already involved with like street outreach. Most of them are grantees for the peer Pathfinder stuff that Lisa and Maida already talked about. And they're getting a little bit less, and they're scattered throughout the state, which is all in the counties around here. So lose my train of thought. So so they're different, but they have basically the same contract language, and they're basically kind of doing the same work with the same eligibility. There's no requirement for them to be engaged with services to get the housing subsidies. There's no requirement for them to be ready. Like, it's up to them if they're ready to be housed, right? And that's part of the contract. But otherwise, the eligibility of people they can help with these specific subsidies are the same. They have to have a substance use disorder. This can be self-attested. This can be medically diagnosed. Occasionally, they'll do kind of like staff observation, because a lot of staff are finding that their initial contact with the program participant, like because of housing, they're afraid that they might be disqualified from a housing program if they divulge that they're using. So sometimes staff will collect information, or they know for a fact that they saw them using, like when they did the initial contact. The entire household has to be under 50%. The household income has to be under 50% of the county's area median income. Hopefully, I recognize most of the people in this chat, so you probably know what AMI is. And then also the other requirement is that they're either unhoused currently, or they're about to become unhoused, and they will become unhoused if they don't get these subsidies. Otherwise, that's pretty much the eligibility for people they can help with these subsidies that they're already helping. And the eligible cost, there's about a page of bulleted stuff, but broadly, it's rental or utility arrears up to 6 months, move-in costs, which could be security deposits, application fees, what have you. But otherwise, the pretty hard max is it's $7,200 max per household. Occasionally we'll go over, because sometimes stuff just costs more in certain counties than other counties. But that 72 max is rarely gone over by a provider. I think maybe twice a provider's asked to go over that amount. But the actual, like, what that actually pays for, like, most of the money goes toward rental debt, which up to 6 hours, and I'm up to 6 months, and a lot of it is going toward rental debt for Oxford and recovery houses. The reporting for my program is different from Kathy and Maida's, because they're submitting information into a database to help with administration and to make this as administratively burdenless, as like unburdensome as possible for the providers. Is that they're sending me with their invoice that we reimburse them, they're sending me basically a spreadsheet with anonymous data on it with really basic demographic information. So ask me in a year and I'll have more data about like who's coming from and going toward Oxford or recovery houses, but just sort of an educated guess, a lot of that rental debt's going toward that. And broken it down by the average for my subsidies, not the outreach one, it's about $1,200 per household that they're spending on. And obviously there's because race is a thing that it varies differently the average per if they identify as a different race or ethnicity. I don't really have that much more information beyond this graph, but I'm trying to look into it as I have like extra time and with just sorry, I just got a question. Oh, I'll answer it at the end. And then we also collect whether or not they identify anywhere in the LGBTQIA plus spectrum. Yeah, here's a bar graph. I don't know what to do with this information. It's decided to share it because we're collecting that information. And then for the outreach subsidies, because they're kind of doing different work and they're serving like a different clientele, their average per household is a little under 1,100, and they're still the average amount per race is a little bit different. And since the subsidies, the contracts for that were executed like January 2024, a little bit before I started. And from February 2024 to the end of the last state fiscal year in July 2025, there's a little over 1,800 distinct households that were served. And because, yeah, and then of them, about 60% we can actually guarantee that they got into or maintained their permanent housing. And then about 20% of them either they marked that they actually went into either recovery home or recovery residence or an Oxford house, which is kind of permanent housing, depending on how you define it. And then about and then about 20% of them either we don't know or we know that like the subsidies at that time weren't able to house them or get them to maintain their housing. And then for the outreach subsidies, it's again from October 24 to 2025, it's about 1,800 with 45% we know maintained or got into permanent housing as a result of these subsidies, and about 30% of them were in either were able to maintain their housing in recovery or in the recovery home or Oxford house, with about 15% in some sort of transitional or temporary housing, however they wanted to define it. Yeah, that's really all I have. I was keeping the slides vague to kind of like open up to more questions, but I'll take questions in the chat, or I'll just put my email if you have more questions.
Did you see the one question in the chat, Brian?
Yeah, would this program be able to pay rental arrears for those behind on their rent living in True Blood housing? Probably. What is True Blood housing? I know True Blood, but I don't think I've seen the phrase True Blood housing before.
You know, I'm wondering, hey, this is Lisa. I'm wondering, I know True Blood has specific funds for that population. But the question would be, do they have current funds that will play for rental? The back pay on the rentals? The answer would be yes.
Yeah.
In our programs, we do know that we pay for that would pay back rent in a case to help somebody maintain housing. But I'm not really 100% sure about True Blood housing. If they're enrolled in True Blood housing, that's a little confusing. I don't know if you're using that term as a person with a criminal background, or you're just using True Blood as a specific program.
Hi. Yeah, it is a specific program, just like the True Blood forensics, verbiage that you're used to. It's just housing, low-income housing specific for that population. So there are a number of houses that are just dedicated to that.
Gotcha. And then I think the answer is I'm not sure, to be honest.
Yeah.
But if you can email Brian, we can coordinate and get you an answer.
Love to. Thank you.
Thank you.
And just to wrap up, I think that like something I do site visits for these subsidies where I'll like go in and I'll talk to the staff and also talk to people that got these subsidies. And like I imagine most of you have some sort of housing program, but like something that's I think a lot about is a client telling me that like it's them getting the subsidies is like he realized he was planning something out like 2 weeks in advance, and he realized that was the first time in like his recent life he was able to do that. So something I just like, I'm sure that like you're aware that like every person that a case manager helps is like, changing their life, but it's just like something about that thread is remarkable to me that I think a lot about, even though I've been kind of in this space for, I don't know, it's my career, like 12 or 13 years in housing and homeless response. So yeah, I guess just reach out if you have any questions. The slides are vague because really it's just, yeah, it's like a nice little tool they can pull out of their back pocket to help somebody out.
Lauren, you ready?
Yeah, I'm ready. Let me go ahead and share my screen. Can everyone see my screen?
Yep.
Okay, great. Okay, I'm gonna start slideshow. Hopefully that won't mess anything up. Can you see the screen?
Yes.
Okay, great. Okay, hello everyone. I'm Lauren Robbins, as I said before, and I support as the contract manager for the Clubhouse Peer-run program for Clubhouse model and RCOs, and I'll also be speaking on behalf of Dre today for Recovery Cafes. So moving on. So the intent of the Clubhouse Peer-run program was to address the unmet needs of individuals experiencing behavioral health challenges to improve social relationships and overall quality of life. And this is done through empowerment, employment and education, and that's actually a contract requirement. Volunteerism, we like the mantra of once a member, always a member as a participant, health and wellness, access to resources, but at the core of that is social connectedness and community. So I'm not going to take a huge deep dive into funding, but just to give you an idea, with the onset of the funding in 2017, legislature provided us with about $1,496,000, and currently today for 25-27, we have a little over $10 million to support our current providers that are receiving funding for ongoing program services each year. So in an organization, when we're prioritizing the funding for expansion, what we're focusing on is we want to ensure that we're serving communities. We're putting these programs into areas that are lacking a Clubhouse Peer-run program. We're also focusing on whether or not the organizations are serving marginalized and underserved populations. When an organization comes on board, they have to identify whether or not they're a startup, as in totally new, development, expanding out, or expansion. They also need to choose a model. So we have 4 different approaches that we use for this program. And that would be Clubhouse International, Recovery Cafe, Recovery Community Organization, and Alternative Promising Practices, which I'll get to take a deeper dive in a minute. We also prefer organizations have 3 years of experience, but if not, we request letters of support. So I want to take a little bit of time here to talk about language, because if you're looking at this from
Lauren.
Yeah.
Sorry, your slides aren't moving.
Oh, they're moving on my end. Okay. You know what? I'm going to get out of slideshow.
Okay.
It looks like you,
now?
yeah, it looks like you shared
Now
the PowerPoint view, but not the slideshow view.
Oh, so sorry. So sorry. Okay, well, my bad. So can you see the slides moving now? Is that yes? Okay.
Yes.
Okay.
Yes.
This is what we're talking about with the program. So I apologize for that, but also you guys will get this PowerPoint. So you can review that as well. My apologies. Okay, so this is the funding I was just discussing from 2017 on, and also the prioritization of funding related to what we focus on for expansion. Okay, now we're up to date. Okay, so when we're talking about the language around this program for a second, just want to highlight that, if you were to pull up a proviso or a bill, you would need to do a Control F and put Clubhouse in there because you're not going to find it under peer. So on legislative speak, you're going to see it under the term Clubhouse. When I'm speaking, for example, in this format here in a PowerPoint or public facing, we like to distinguish the difference between Clubhouse model and the peer-run models separately based on their unique characteristics. For example, Clubhouse International is its own model. So we speak to that differently and we identify that clubhouse as a clubhouse. Under peer support models, we focus on recovery community organizations, recovery cafes, alternative promising practices. So let's take a look at what that means. This is a very high overview of each one of these models. So I'm just going to touch base on these. But when you receive this PowerPoint, know that if you hover over these icons, it's going to take you to links and additional videos related to these models. So we'll start with Clubhouse International. So Clubhouse International started, the first Clubhouse was in 1948. It is an evidence-based practice as of 2011, and it focuses on psychosocial rehabilitation. Their focus is serious mental illness with adults serving adults 18 and older. When you become a Clubhouse, you join Clubhouse International and receive specific Clubhouse trainings. Clubhouse has very specific standards that they require you to follow, 37 standards. Participants are considered members. And at the core of a Clubhouse is the work order day. That is what the Clubhouse functions around on a daily basis with the members. They do provide vocational supports and housing supports. There are 370 clubhouses globally in 32 different countries. So this program is across the globe. And 10 Washington State clubhouses, 4 of which are accredited, and HCA supports funding for 10 Washington State clubhouses. So on recovery community organizations, we follow the Faces and Voices definitions of best practices that was founded in 2001. So some of those best practices would be that they're peer-based, that the organization be a nonprofit 501c3, led and governed by the recovery community, that they're grassroots, that they have peer support services, mostly adult 18 plus. We do have some organizations that have some youth-focused programs. DEI should always be a focus as well as recovery language, and you should support all pathways to recovery with this particular model. And also ethics and grievance policies should be at the forefront when building out the program. And there are 17 HCA funded RCOs in Washington. So I'm sure you've probably heard of recovery cafes. So the Recovery Cafe was founded in 2003. It's an evidence-based, they focus on evidence-based practices such as recovery-oriented systems and the 10 SAMHSA recovery components. When you come on board if you say you want to be a Recovery Cafe with this funding, then you join the Recovery Cafe Network, which is the RCN, and you become a member, and they have specific trainings, cohort trainings that help you build out that Recovery Cafe. Serving mostly 18 plus, they have started a youth pilot program, which is, I think in the last year or so, which we do have Recovery Cafe Clark, who has actually an RC youth program that they've implemented as well. There's social, emotional support, social/emotional supports. They also have School for Recovery, recovery circles. They provide resources and some vocational training as well as task building. This is a nationwide program. So there's 77 RCs nationwide. There's 18 recovery cafes in Washington alone, and HCA supports funding for 13 of those. The last one we're focusing on is alternative promising practices. This is something that HCA has built out with this program to provide a space for our tribal communities in case they do not feel like they fit into any of these categories. And this provides our Native American tribes to incorporate their own healing practices around providing services and supporting their tribal members. We work very closely with HCA's Office of Tribal Affairs to ensure that we are using proper language and using appropriate interactions with our tribal communities. We currently have one tribe, Puyallup tribe, that's receiving funding. Some of the provider supports that HCA provides is we have 5 different organizations that help facilitate our learning collaboratives, and these are very specific, focus on any type of provider related topics that might support our providers, but also we do have an honorary guest every year now, and we had the tribal community support this year, which we were really honored to have them on board. I spoke about expansion earlier, so this is just to give you an idea. As of 2021, we had 14 Clubhouse Peer-run organizations. We did massive expansion with this funding in the beginning. So we had 5 clubhouses in the beginning, 5 recovery community organizations, and 4 recovery cafes. And as of now, we have 42 clubhouse and peer-run organizations. I won't go over each number, but we've done quite a bit of expansion, so we're very excited about that. A little bit on community impacts, just to show you, this is cumulative numbers over the entire year. Since we started back in 2017, we've had over 34,000 enrollments. We've had over 30,000 basic needs provided, over 10,000 employment services, and over 18,000 educational services. So that's pretty much it. That's all I have for now. Do we have any questions?
I don't see any questions. You, Kim?
I don't see anything.
All righty. Next
Okay.
is me again.
Next.
Next is me again. I'm going to do pre.
Didn't we already hear
Oh.
from you, Lisa?
Yes.
Kidding.
I love to talk. Okay, let me get to this. So just a little bit more about me. I've actually been in this field for a little over 30 years now. You never know, right? Anyway, supportive employment was a huge piece of my career. It was a huge piece in my career. I look at employment education and what that has done for people, whether that's somebody that's in recovery with mental health condition, or in recovery from substance use, or just in recovery from experiencing poverty for a long period of time, how employment makes people grow in so many different ways. We had a program that's just about 2.5 years in the making. It's called Passageway to Employment, or PRE. Actually, it's Passageway to Employment Education, Employment and Education Grant. Would you believe I named this program? Anyway, but we call it PRE. It was a proviso that actually came out in fiscal year 23 to establish an employment and education, a key piece, employment and education grant designed for persons with substance use disorder. And that was through our opiate abatement settlement. The grant also specifically stated in the proviso that these funds needed to be prioritized for individuals that are Black, Indigenous, persons of color, and other historically underserved communities. So that was unusual and great. It's been a great I guess test and seeing how well we can serve these populations if it's a requirement. And I'll be able to show you the data in just a minute. Unfortunately, it's not the largest grant. It's fairly small grant in that we have 5 providers. Consistent Care in Pierce County, Community Minded in Spokane, Native American Reentry Services, which covers primarily Pierce and King County, but also serve people in general coming out of prison. Pier Washington, and that's 3 different locations. One, Thurston, Olympia and Mason County, and Seattle and Kent. And then we have Yakima Neighborhood Health Services in Yakima. Who's eligible for pre-services? So it's a person's experiencing a substance use disorder, not necessarily in recovery, but person experiences substance use disorder. It could be any spectrum of recovery. Persons unemployed and or underemployed. So some people will actually come seeking pre-services because they're in a job that's not making the bills, right? They're working and they want to maybe get some further education so they can help increase their income and increase the quality of life. Priority given to persons who identify as Black, Indigenous people of color, and other historically underserved communities. So basically what we did is in contract language, each provider knows that they need to serve a minimum 50% or more of people that they're serving would fall under this category. And we hold them accountable for that. There's low barrier entrance, no required proof of treatment or sobriety. And job readiness is based on interest and not based on artificial indicators of job readiness. The services we provide. So there's your basic vocational planning, gathering skill sets, or your interest, goal setting, getting somebody to actually identify a goal that they would be interested in doing, something where the job market allows for it, goal setting based on education tracks or not, resume and application assistance. And then also one of the things that are specialized about supportive employment versus your traditional employment services, that piece where there's job development in the community by the agencies on behalf of individuals. So you actually have a job developer that goes in the community, meets with employers, finds out what their needs are, and then tries to match people skill sets, or people on their caseload skill sets, to the needs of the employers. Education guidance. So again, just like job development, these employment specialists have a relationship with community college. Community colleges may be short-term classes that are being offered, and or people that are interested in extended education or formalized education, 2-year, 4-year, 6-year education track. Employment, as far as prep program goes, we will support somebody up to a year in those scenarios, but we support the decision that people make to further their education, what that looks like. We will support them for a year or below programs where financial aid isn't available from other resources. We will support them in providing that funding. There's also benefit counseling. So when somebody is in contemplation of going to work because maybe they're afraid that they have low income housing, how will the low income housing be affected by going to work? Generally, the people that we're serving in this program are not on Social Security, but they could be on Social Security. So then you'd want to know, how would my Social Security be affected if I went to work? I receive food assistance. How will my food assistance? Things like that. Then follow along support. So the key to supportive employment is, one, we don't have a crystal ball. We don't know what kind of support somebody needs. And sometimes they don't know what kind of support they need. It should be assumed that everybody would benefit from follow along support, meaning that which it could look like way different things. Somebody's follow-up support might be as minimum as the first week. Let's call before you go to work. Let's talk at lunchtime, but it's something that's planned in case there are bumps in the road along the way. Maybe there's a problem with communication with a coworker. Maybe it's they're feeling overwhelmed and they just need somebody to brainstorm some ideas of organizing themselves. Whatever that support looks like. It could be support on site if something that was discussed early on with an employer, which I'm going to backtrack to job development. Job development on somebody's behalf also has some disclosure to it. So the employer knows when you're bringing them somebody, that you're bringing somebody that is, maybe, in a program that supports people with substance use disorders. It honestly depends on what you decide with the job seeker and what will be disclosed and what won't be disclosed. But there's somewhat of disclosure there. So in the cases where the employer knows, there could be some on-site support to the employer and or the employee. We also have barrier removal funds and education funds. I'm not going to go through the long list of things that people may or may not get, but in the pre-program, we can provide assistance on vocational and technical college training using the first resource of federal student aid, occupation-specific enhancement education, which generally aren't funded by federal student aid, prerequisite classes, college applications, placement tests, part of all that pre-federal aid support that a person might need. And then technology as related to education pathways. So they might need a laptop, for example. More barrier removal things are the type of things that stop somebody from even getting started, like transportation, which could be, gas card, bus pass, small car repairs, short-term insurance installments, driver's license, reinstatement fees, the cost for the license, all these type of things. And they're also really powerful things for an individual to achieve when they're on that track of recovery and looking for employment. There's also other barrier removal things that a person might experience, like interview closing, housing. Housing could be a barrier. So for this, for we allowed for some basics for housing, like Oxford shared housing, transition housing, registered recovery residences, and some other type short-term housing. We also connect and work with the housing subsidy program because we also have that available to us. So we have a cap limit to what we can spend in this area. I think I'm getting close to my time. I got a couple more minutes. There are referral pathways. There's no wrong door. There's no wrong door. It could be a self-referral. It could be a referral from drug court. It could be a housing program. It doesn't really matter which door they come in, just that they meet the criteria of eligibility. So just a little bit of data. This is our fiscal year 25 data. Again, we're not far into the data quite yet, only being 2.5 years since we actually started services, and services take a good year to really get going. But we have about equal when it comes to the portion of people that start with an employment, go the employment track, and then the people that go the education track, but realizing that the education track could also be and should be the employment starts as well. So there might be some of the same people. And then we have a portion of people that are either pending employment or education, or we've lost contact with. Last thing is, as fiscal year 25 data shows that people identify BIPOC, 85% of the people that were in the pre-program served identified as BIPOC. 85% of the people. And that's everything. Any questions?
I don't see anything in the chat. All right. Well, if you do have additional questions, something comes to you, you can definitely reach out to any one of us, and we'll make sure you get your questions answered. I just want to say a big thank you to the recovery and community team. great programs. Exciting to hear all the great work that's being done in our communities. I am lucky to be working alongside you all and get to hear this stuff. And that's why I wanted our provider network to be able to hear all the great programs that exist out in our community that may not be known about. So thank you all. Thank you, Lisa, Lauren, Maida, Brian, Kathy, for all being here today. I was like, am I missing somebody? I always feel like I'm missing somebody. And just want to say that we will get the slides out to you. I'll have the team send me their slides and we'll get them out, as well as we do record these. And so in a couple days, this recording will be up on the FCS YouTube channel for future viewing if you have other folks that might want to listen in. Don't forget, we are here every month and have a great new topic next month. And so we look forward to seeing you on the last Thursday of February. I hope everyone has a great rest of your week, and we'll see you next time. Thank you.
Bye.
Goodbye.